Assalamu alaikum. The article for this week is titled with Effect of Apical Third Enlargement to Different Preparation Sizes and Tapers on Post-Operative Pain and Outcome of Primary Endodontic Treatment. A prospective randomized clinical trial done by Shazra et al. And published in 2021 in Journal of Endodontics. As we know, the aim of endodontic treatment is to eliminate microbial infection and prevent reinfection of the root canal system. It has been considered that the apical third is a critical zone since it's rich with the presence of anatomical variations such as isthmus, ramification, and lateral canals. An adequate apical preparation is debatable because some authors reported that the apical preparation to large sizes is required to disinfect the canal adequately, but it results in an unnecessary removal of dentin, leading to weakening of the tooth structure. Also, it has been demonstrated that the larger apical preparation allows penetration of irrigation, lead to a significant reduction in the number of residual bacteria. In contrast, it has been proposed that the minimal apical enlargement can minimize the risk of procedural errors such as apical transportation and zipping. There is no agreement on the ideal apical preparation size and taper that will result in the least incidence of postoperative pain and promote optimum healing of the periapical tissues. So this study aims to evaluate the effect of apical preparation size and taper on postoperative pain and healing after primary endodontic treatment. Regarding the material and methods, patient with asymptomatic apical periodontitis in a mandibular first molar with radiographic evidence of periapical radiolucency corresponding to a periapical index score greater or equal 3 were selected for the study. For the exclusion criteria, patients who were medically compromised or pregnant or had uncontrolled diabetes, smokers, and also patients with a history of analgesic intake in the past 1 week. Patients were divided into 2 groups and 2 subgroups based on the size and taper of apical preparation. It was as follow. Group 1A, 2 sizes larger than the initial apical binding file with a taper 4%, and the group 1B, 2 sizes larger than the initial apical binding file with a 6% taper, and the group 2A, 3 sizes larger than the initial apical binding file with a taper 4%, and the last one is group 2B. The canal was prepared 3 sizes larger than the initial apical binding file with a 6% taper. 60 patients for each group. Endodontic treatment was performed in 2 visits using calcium hydroxide as intracanal medicament for 1 week. The assessment of pain at the interval of 6, 12, 24, 48, and 72 hours, and the change in periapical radiolucency at 3, 6, and 12 months follow-up were measured. The clinical success of the cases determined by the absence of pain on follow-up visit and the absence of tenderness on percussion or palpation, and the tooth or the case no associated with sinus tract or evidence of soft tissue swelling, and lack of abnormal mobility of the tooth and periodontal probing depth within normal limit. Regarding the result of this study, of 120 patients, 5 patients were dropped out, 115 patients were evaluated for the assessment of post-operative pain and the outcome of the treatment. Regarding the post-operative pain, there was no significant difference between groups at the interval of 6, 12, 24, 48, and 72 hours. And age, gender, and pre-operative lesion size did not reveal any significant relation with post-operative pain. For the periapical index score, cases were considered success if the periapical index score was less or equal to, with absence of clinical signs and symptoms at the 12-month follow-up. The success rate were 57% for group 1A, while others ranged from 92.8 to 96.1%. A significant difference in the change in the periapical index score between group 1A and the rest of the groups at 6 and 12 months follow-ups. The results showed that a significant relation between the master apical size and the preparation taper and the outcome of the treatment, and also there was no association between age and gender and the outcome of the treatment. From this study, they concluded that post-operative pain is not influenced by the apical preparation size and taper of the instrument, and also apical preparation to 2 sizes larger than the initial apical binding file with a 4% preparation taper is insufficient and results in a lower success rate compared to other groups with the larger sizes and taper. The minimum apical preparation size required to adequately disinfectant the canal was 25 with taper 06 or 30 with taper 04 in the majority of the cases in this study, and further enlargement of the apical third to larger size and taper does not result in a further significant improvement in the success rate of the treatment.